Dr. Simon?
Yeah, ready?
Yeah, how are you?
All right. Good morning, everybody. I'm Jag Sundaram, the Division Chief of Pulmonary and Critical Care Medicine, and it gives me great pleasure in introducing Dr. DeCamp this morning, who will speak to us about the ethics of AI in medicine. As you know, AI has become part and parcel of life these days, and more so in medicine and in education. And so we have, started to realize that there's a lot of advantages to AI, but a lot of questions and whether AI would replace us in the future. And I think Dr. DeCamp is the best person to talk to us about these issues and the ethics of AI. He's an associate professor in the Center for Bioethics and Humanities and Division of General Medicine, Internal Medicine. He completed his medical and graduate education at Duke University, his internal medicine residency at University of Michigan, his postdoctoral training in bioethics and health policy at Johns Hopkins. A practicing internist, social scientist, and philosopher, Dr. DeCamp employs both empirical and conceptual methods to identify and solve cutting edge problems at the interface of healthcare, policy, and bioethics. Special emphasis of his research includes engaging patients, families, and community in healthcare research and care, global health, and ethical issues in artificial intelligence. He serves as Director of Research Ethics for the Colorado Clinical and Translational Science Institute and is a member of the Partnership of Academicians and Communities for Translational Council of the CCTI. He will speak to us on the bioethics of AI. So, Dr. DeCamp, a real pleasure. Please go ahead.
Well, thank you for that introduction and thank you for this really special opportunity. It's a pleasure to be with you all this morning and talk a little bit about AI. I say a little bit because it's already hard to cover everything about the ethics of artificial intelligence in medicine. But this morning we're going to try. So thanks again for this opportunity. I'll try to speak rather quickly with the hope that we have times for questions and answers toward the end, because I actually want to hear from you and understand how you're using AI, what you think about using AI, and what you're thinking about for the future. I don't have any financial disclosures. I will touch briefly on two of these research projects we have ongoing. The R25, unfortunately, is no longer funded. And anytime I mention a product during the talk, it's really just for illustration, not any kind of endorsement. These are our objectives. We'll be able to describe a few ethics issues. I'll have some practical strategies and tips along the way. And lastly, I'll dive deep and argue that AI is more than just a tool we use. So I hope by the end of this presentation that you might question the common phrasing we often say, which is, well, it's just a tool. It's just a tool we use. So I hope you'll question that by the end. As you said in the introduction, as you all probably know, the AI wave is already here. This is an image that just shows the diverse array of uses of AI already in healthcare. On the top, clinical applications in orange, ranging from population health management to direct treatment recommendations. On the bottom, automation of tasks, recording digital notes or ambient note-taking, optimizing operational processes, care management, and so on. So AI is already affecting all of these. And if you can believe it, there are now more than 1,000 AI-enabled FDA-authorized uses and counting. This has been an exponential rise in FDA approvals or authorizations, I should say, over the past couple of years. These are a few more concrete examples that you may have heard of. And on the left, some general categories: predictive analytics, image interpretation, chatbots, caregivers, and other robots. And you can see more specific examples on the right, whether it's AI-based mortality prediction for palliative care. That's an ongoing study we have. Whether it's interpreting chest x-rays or taking pictures and helping interpret moles, ambient note-taking, patient portal messaging, as I mentioned, and those caregiver robots used a lot in countries like Japan. If you've heard of Robert or Pepper, Very interesting use of technology. I won't talk about caregiver robots today, but you can imagine those raise ethics issues all of their own. Now, all of you may already know how AI works, but I think it helps to get us thinking and talking about AI to understand at least the basics from an internist bioethics perspective of how AI works. So let's start with predictive analytics. How does AI predict the future? Well, many of us are familiar with the idea you can use basic chart data like height, weight, blood pressure, and so on to make predictions of future disease. Now with AI, imagine you have millions or billions of data points. You can again follow patients over time and ask questions like which factors predict who gets heart attacks. And then the power of AI should be that we can identify new factors and make better predictions. Statisticians will tell you that many of the methods used for predictive analytics and AI are not new. It's really that we have more data, more computing power, and we're able to make better predictions in that regard. What about image interpretation? How does AI learn to see? Well, here I'll share with you something that's been popular on the internet that tries to solve one of the most vexing problems in society and medicine, and that is how do we sort pictures of blueberry muffins from pictures of chihuahuas? Well, if we wanted AI to help us solve this problem, we would get an AI image analyzer, and we would just start showing it pictures. There's a blueberry muffin, there's a chihuahua. We have a gold standard supervisor, that could be you or I. We stand over the AI to supervise it, to correct it when it gets things right or wrong. And we keep showing it pictures. There's a muffin, chihuahua, chihuahua, muffin. You can see not exactly an easy task, as it turns out, for AI to make these interpretations. We just keep showing it pictures until it gets one wrong. And that's where the gold standard supervisor comes into play. We're there to correct it, to say, no, that is a chihuahua. And that's how it learns over time. Now you can imagine what would happen if we showed it this picture, a Saint Bernard. Well, number one, in either case, it will be incorrect. And number two, it's really hard to predict how this classifier will end up classifying that particular picture. And this will be an important point when we talk about the data behind AI. Last but certainly not least, how about those generative models? How does ChatGPT generate content? Well, my colleague in the Department of Biomedical Informatics, Casey Green, says ChatGPT is like fill in the blank. We all know what comes next in that sentence. Casey also says that ChatGPT is like the annoying friend at the dinner party who insists on completing your sentences before you do. That, in a nutshell, is how ChatGPT operates. But how does it do that? Well, it's been trained as well. It's been trained on the internet, on publicly available books and articles with a smattering of human oversight to make that prediction of what comes next in a particular sentence. Now, the common thread among all of these, whether it's predictive analytics, image interpretation, or generative content, is that AI is only as good as the data used to train it. This turns out to have great explanatory power for how we think about each of the ethics issues that we'll cover in the rest of the presentation. So please keep this in mind. Now, many of us in bioethics ask this question: as this wave is here, as the tide is coming, so to speak, can our ethics principles influence this tide? It turns out we've had plenty of ethics principles over the past 5 to 10 years developed for AI. This is the World Health Organization. The White House had previously put out a Bill of Rights. The European Union has many principles and legal regulations around this. AMA, Asilomar, national academies, and so on. So in the rest of this presentation, I'm going to do a little bit of a rapid fire format where we go through quickly each of these principles, some of the common principles that are used to shape AI, and try to move toward what they might mean for their practical application. And that will reveal, I think, some challenges along the way. Challenges for how we think of the principles, and challenges for what they might mean in that practical application. I'm going to start with this first principle, common to many AI ethics guidelines. Be transparent. Be transparent in the use of AI. Transparency about the use of AI really seems foundational to every other ethics issue we could imagine, whether it's informed consent, reducing harms, protecting people's privacy, or having responsibility for medical error. It seems so foundational to each of these. But despite the apparent simplicity of transparency, I think it's actually complex. I analogize this to windows with differential light transmission, where it seems reasonable to ask how much transparency really is enough. Now, if we turn to the AMA, the American Medical Association recent guidelines on augmented intelligence in healthcare, these guidelines do emphasize transparency, and they're really important. They first of all emphasize a risk-based approach, where the level of scrutiny, validation, and oversight, and so on, that we apply to AI should be proportionate to the overall or disparate harm and consequences, this risk-based approach for how we think about transparency. Secondly, they note that use of AI-enabled technologies should be clearly disclosed to patients. This is a clear statement of transparency. And then additionally, they say that when AI is used in a manner which directly impacts patient care, that use should be documented in the medical record. And here, I ask a question. This idea of disclosing and then documenting in the EHR each and every time that we use AI in healthcare seemed to me worthy of being questioned. Why do I say that? Well, in our interviews that we've done with clinicians, families, patients, caregivers around the country, we've sometimes heard quotes like this from our clinician interviewees around the use of AI-based mortality prediction. I don't document my use of up-to-date journals or other sources in my EHR. Why should I do so for AI? What information needs to be disclosed really when it comes to AI? And who's the best person to disclose that information and how? Particularly because a number of our AI systems operate back here. They operate in the background of the healthcare system. And should we place the burdens of disclosure and documentation on frontline clinicians who frankly may not even be aware that AI is being used? And you see here the first hint of this question of whether AI, as the slide suggests, is exceptional, or are we engaging in exceptionalism? That is, holding AI to an unduly high standard, a standard that we don't hold the rest of medicine to when it comes to transparency and disclosure. But let me make this even more real by introducing you to our patient-facing chatbot, Livy. This is a chatbot that's within our own healthcare system. In the center of this slide, you can see a conversation I had with Livy, where Livy helped me fill out advanced care planning documents. Now, you can imagine the power of patient-facing chatbots like Livy. They could offload administrative tasks like scheduling, deliver personalized care recommendations like colonoscopy or mammogram reminders. Livy, in our case, is attached to the EHR. That means at the end of my conversation with Livy, Livy could say, "Oh, Matt, I happen to notice you're overdue for your colonoscopy. Let me get that scheduled for you," because Livy knows I'm overdue. You can imagine technologies like this could really break down geographic barriers to access to care as well. So a lot of benefits to chatbots like Livy. But what about transparency? In our research with Livy, we've surveyed more than 600 patient users of the chatbot, and we asked the first and I think most basic question of transparency. When you were interacting with Livy as a patient, what did you think Livy was? You can see here, this slide shows you that 1 in 3 people weren't sure. And some even thought Livy was a real person typing back in real time. What's more, correctly identifying Livy correlated with education and race or ethnicity, but interestingly, not age, not gender, and not income in this study. A clear reflection of the challenges we face in the real world, even when it comes to that most basic ethics question of transparency. Now, there's a closely related concept in AI ethics that's called explainability. How do we explain how AI came to the recommendation that it did? It's slightly different than transparency, but it's clearly related. So what if we look at that AI-based chest X-ray interpretation? And we want to know, well, how does AI come to a conclusion that there's a pneumonia in this right lower lobe, something all of us as clinicians would quickly identify, I would say. Well, it turns out we can ask AI. We can say, AI, how did you come to that conclusion? And AI can show us a heat map like this one, where higher numbers indicate greater influence over the final interpretation on the heat map, greater influence over AI's final interpretation. And what you'll notice if you're looking at this and those numbers, you'll see that all the higher numbers are at the bottom, below the lung fields. This seems inexplicable. This is hard to explain from the standpoint of AI, and it's why people care about the notion of explainability. Now, in our research on AI-based mortality prediction, we hear different views about the importance of explainability to ethics from our physicians across 4 major centers. Views about this black box that you see in the center of the screen. Sometimes we hear this, I'm a communicator, and I need to be able to tell people that I have this tool, this is how it works. Other people are not as concerned about explainability. They say things like, that wouldn't really bother me too much not knowing the nitty-gritty. Again, there's so much care delivery that happens for my patients that I don't know, and so on. So what do we really make of explainability? We followed those interviews of clinicians across the country up with surveys. In our national surveys, you also see this reflection of concern about the black box. More than 75% of our survey respondents say they're at least moderately, if not very concerned about black boxes when it comes to AI. But are we right? Are we right to be so concerned? Philosophically, many believe that knowing how something works is more important than knowing that something works. And I think the concern over explainability reflects this. But some would say there's a caveat here. And several caveats, in fact. The first being that some would say the blackest of all black boxes is this one, the one that sits atop clinicians' own heads and may make decisions based on biases and other irrelevant facts. We also know that clinical trials are not always causal. We know that statins work, but over time, the explanation for how statins has worked has changed. So again, we're hearing elements of perhaps exceptionalism in holding AI to an explainability standard that we don't hold the rest of medicine to. And lastly, if push came to shove, some tech people tell us that there could be a trade-off between accuracy of a model and explainability. When it comes to a decision about your or a loved one's healthcare, if you had to pick the one that's more accurate or the one that's explainable, I venture to say that many of us would pick the model that's more accurate if push came to shove. So explainability, while important, ought not be over-exaggerated in the way we think about ethics and transparency for AI. There are many new challenges coming to transparency, by the way, and here's one. We flagged this issue years ago, the idea of digital twins of physicians. And already I was at a conference a few weeks ago where health systems, citing patient experience and other factors as this is the right thing to do, are creating digital twins of physicians to interact with patients after hours. So now you log onto the system after hours and you get the digital representation of me, your primary care physician, my face, my likeness, my voice, talking back to you, powered by large language models. Clearly a new challenge to transparency, I would say. So the take-home point from this section, transparency. I do think ethics suggests that we err on the side of disclosure, but like the rest of clinical medicine, this has to be tailored to the unique circumstances of each patient and the clinical context. I think it's too far to say disclose and document in every single case that AI has been involved. We can be thoughtful like we are just in the rest of clinical practice. Principle number 2, sacrosanct principle in medicine, do no harm. Whatever else we agree on, the idea that we should at least do no harm when using AI seems reasonable, but will it be so easy? And patients come to us, and instead of asking Dr. Google, they've asked ChatGPT. Or perhaps we've asked ChatGPT or Open Evidence or other programs like it to help make clinical decisions. Here's a real-world illustration that I call a tale of two chatbot queries that illustrates the challenge of using AI in medicine. On the left, cardiovascular disease prevention queries. This is the idea of asking ChatGPT questions like, how can I decrease my LDL? In response, 21 of the 25 queries were appropriate in their response to this question. Although one response said that the drug inclisiran was not available. Why was that? Well, this was because of the knowledge cutoff date. AI has a date beyond which it has not seen new data. And if it has not seen, so to speak, that the FDA approved inclisiran and it's available, it will tell you that that drug is not approved. So be mindful of the potential knowledge cutoff date for new or cutting edge therapies. But overall performance is pretty good. Let's compare it to a different domain, advanced ophthalmology queries, where we might ask questions like this one. What are the treatment options for central serous chorioretinopathy? Here, look at the difference in performance. Only 8 of the 52 were completely accurate, and 2 weeks later, 26 of the 52 answers changed. 16 were better, and 10 were worse. So very different performance based on the knowledge domain under study. Here's a different example of the same phenomenon from my own work. I went to ChatGPT, and I said, can you summarize medical ethics in 100 words? And it does a pretty nice job. It says medical ethics is a branch of ethics that deals with the moral principles guiding healthcare practice. It focuses on 4 key principles: autonomy, beneficence, non-maleficence, and justice. It does a nice job of summarizing these 4 principles. But I know, as someone trained in medical ethics, that this is not the only approach to medical ethics. In fact, this is the Western bioethics approach that really is only developed since the 1970s. But what you see here is a reflection of the extent of the publicly available data used to train the model that reflect that Western bioethics approach. So we're seeing elements of that common data thread in the answer to this question. Now I know because of this that I can ask ChatGPT a follow-up question. I can say, what approaches did you leave out from that answer? And in fact, now ChatGPT obliges and said, well, here are all the things that I left out: virtue ethics, deontology, consequentialism, casuistry, narrative ethics, and more. Because I knew that that particular response reflected a bias, I would say, in the literature, I knew to then ask it a follow-up question to get it to reveal the parts of the answer that it had left out. You can see how this might narrow the knowledge base, putting these together for our learners. As learners engage with ChatGPT, if taken at face value, not asking follow-up questions, not knowing to ask the follow-up question, this could really narrow the knowledge base that we use to make decisions. So the take-home point here from the do no harm section: fields where the training data are both broader and deeper are likely to be more accurate. And keep in mind that last date of training data. And lastly, develop your prompt literacy. This is a new competency in medical education. Maybe you're already talking about it, but this is the idea of teaching people how to ask AI the right questions, knowing to ask the follow-up questions, and so on. A major effort, a major need, I would say, as we move forward to interact with technologies. I've already hinted in the prior 2 sections about this issue. How do we mitigate bias in our AI models? What is bias? How do we mitigate it? Philosophically, bias is really any systematic unfair weighting of a person, a thing, or an idea. And I think if we keep this broad notion of bias in mind, it's really powerful for how we think through biases that can arise in AI models. Let me give you an example. Let's go back to chest X-ray interpretation. Just reading a chest X-ray. It seems simple, right? But would you believe that when we have AI image interpretation, it results in significantly more underdiagnosis in some people versus others? Underdiagnosis in people who are female, Black race, Hispanic ethnicity, on Medicaid, or importantly, from the standpoint of justice, have more than one of the above. That is, they suffer intersectional disadvantage. It performs less well for those groups, even though it's just a chest x-ray. Some would say, how could it be biased in that manner? A picture, however, can be worth 1,000 words. This is an image that was generated by AI. I'll give you a moment to look at it. Now let's read together the prompt that generated this image. Traditional African healer is helping poor and sick white children. A shocking example. It's as if the training data in this model cannot conceive of anything other than this, because this is the type of picture that it's been shown for this particular scenario. This reflects the average of what it's seen. A shocking example of biases lurking in particular models. Where does bias come from? Well, I like to think of bias as a three-part problem. We have biased data sets that undergo bias processing, and then we have biased outputs and use in the real world. Let me show you a couple examples of biased data sets, because we certainly have plenty of those. This is a complicated image. I just asked you to follow the yellow piece of pie. The yellow piece of pie shows you the eventual overrepresentation of North American and European ancestry in our cell lines, our biobanks, our data sets, and more. We know that there are longstanding inequities in enrollment in clinical trials by race or ethnicity. When those trials do not fully reflect the human experience, our community, that means that those data sets are going to reveal biases because of how they are built. And there are also odd forms of bias, because as an ethicist, I'm concerned about all biases in our data. This is an image I created from a JAMA publication where the researchers said that, in fact, the AI models in use today come from data in preferentially 3 states. 3 states supplying most of the data for our AI models, and those, not surprisingly, are the states that are in green, a different form, perhaps, of a geographic bias in the way our models are built. I want to illustrate this by going back to our R01 study, that 4-year study of AI-based prognostication, the proverbial crystal ball that can predict your death and flag it in the EHR 2 years in advance, some would say, 6 months, 1 year, 2 years. Some studies, believe it or not, even say 4 years in advance predicting mortality. This, you can imagine, raises lots of ethics issues, the use of AI-based mortality prediction. And I'm going to use it to illustrate the bias question. When we take a closer look at the models that are used, we'll sometimes read statements in the papers like this: the overall accuracy is reduced in certain subgroups, such as racial and ethnic minorities and less educated individuals. This is an example of bias in a model. Differential performance based on some groups versus others. What are the ethical implications for a tool like AI-based mortality prediction if the model is biased? What about for motivating serious illness conversations? We might say, okay, it's just a conversation. What about determining hospice eligibility, however? What about deciding as a primary care physician, as I might, that if I see a high mortality score, I no longer offer preventive services to a particular patient? Or lastly, in states where it's legal, what about using a tool like this for eligibility for physician-assisted suicide or medical aid in dying, knowing that the tool performs differently for some groups versus others? A key challenge, I would say, for ethics, keeping in mind this, that the setting in which this tool was validated and designed may not have included all of these particular outcomes, right? It may not have been designed for these purposes, but we sometimes allow it to creep. It creeps to other places and other parts of medicine simply because we've used it in one context. What should you do if you know an algorithm is biased in this way? Again, when we go back to our study of more than 80 physicians, patients, and families across those 4 US centers, we sometimes hear that using a biased algorithm is okay. There's still value in using an algorithm like that. We use something similar for cardiovascular disease. We know that it is more accurate for certain swaths of the population. Sometimes people say it's not okay. That's such a slippery slope. It just means that it's okay to have inequities because it's a little bit better for everyone. A real challenge in practice for what we think about biases and how we use AI algorithms. Now, fortunately, there are ways to mitigate bias in algorithms. When it comes to biased data sets, we can engage communities as partners so that they want to contribute data and remedy those inequities in data in our science. There's actually evidence that if we create diverse teams, diverse scientific teams, we may be less likely to make biased assumptions and be more likely to identify biases in model performance. And when it comes to biased outputs, I didn't talk about this, but we can also reckon with the underlying social and structural inequities that exist in healthcare today. In this way, AI simply becomes another way of seeing those same problems that we already deal with. And you'll notice something about these solutions. They're not strictly speaking just about the data. They're actually social solutions. And that's why I like to say that biases in AI are not just a data problem. They're really a social problem. We'd be remiss if the only thing we focused on for bias in AI models is just the data. It's not just a data problem. It's also a social problem. When we think about fairness, you may soon be hearing about this, the idea of nutrition labels that are applied to AI models. This is an example of one on the left that has various characteristics of a model, done for the sake of transparency, I might add, that first principle. Now, you might think labeling AI as fair could help fairness and transparency, and I think it might, but remember this. Here's an illustration of different ways of looking at fairness within an AI model. If you looked between the red boxes at only accuracy and precision in this model, black versus white, you might say this model performs pretty equally between the groups. But now look in between the red boxes. And you can see that when we look at positive predictive value or recall or negative predictive value, the model falls apart. All of a sudden it becomes inequitable. And this illustrates a very important point for AI fairness. In the real world, under real world conditions, we cannot meet all dimensions of statistical fairness at the same time. We simply cannot meet every statistical definition of fairness. And this is known as the impossibility theorem. It's the impossibility theorem of AI fairness. Thankfully, this has been reflected in recent models for managing algorithmic bias in healthcare. This is a citation to one. Encourage you to look at this. But I just want to highlight one of the guiding principles that I say is an implication of this impossibility. And that's the idea that we have to move from labeling something as unequivocally fair to explicitly identifying healthcare algorithmic fairness issues and trade-offs. We don't get to say a model is unequivocally fair. Instead, we need to make sure that we make clear and transparent the various trade-offs in fairness that we're making. The very important implication that stems directly from the idea of AI and the impossibility theorem. This brings us to a follow-on question, which is, well, we have different metrics. Which metric is best? How do we choose which metric for a particular scenario? So you might imagine we have two different situations where AI is used. AI could be used to deny prior authorization requests. That's happening. We know that. Or AI could be used to predict future heart attack risk. You might say, well, we have two different fairness metrics. One could be equalizing false negatives, that is equalizing false reassurances between groups. And another could be equalizing false positives, that is equalizing false alarms between groups. This is really hard to get your head around. You have to think statistically with this, but I think it's a challenge for us to work through because tech people are really thinking about these metrics and how to use them. Now, some would say that the connection, the matching exercise goes this way. Then when it comes to prior authorization requests and harm from denial, we want to equalize false alarms between groups. But when it comes to something that's preventive between groups, we want to equalize false reassurances. This is a tough problem. I encourage you to think about it on your own. But the general ethics point is this: we need to tailor our metrics to context. We need to make sure that the metric we choose to equalize between groups, because we can't equalize them all, needs to be the right one for a specific clinical context. This is going to be really important moving forward, by the way. I like to point this out that in 2024, HHS finalized a rule that makes algorithmic bias a matter of concern for healthcare entities. This is happening in states too. My own state of Colorado has legislation that reflects the concern over algorithmic bias. It defines AI and patient care decision support tools broadly along protected characteristics or what it's concerned about, and then really importantly, assesses liability at the individual or health system level for whether that covered entity made reasonable efforts to identify and manage biases in algorithmic performance. That's where these metrics are going to come into play when you develop your AI governance structures. They're likely to be part of what you say you've done to identify and manage bias in algorithms. Which metrics did you use and why? So the take-home point when it comes to identifying bias, be sure models are evaluated along multiple dimensions of fairness using different metrics so that we can make sure we uncover bias in different ways. Promote choice. This is the last of the ethics principles I'll talk about, and I'll move to that deeper issue. AI clearly influences our choices. Would you believe that Netflix claims 80% of choices on Netflix are made because of their AI recommender system? We've asked about questions of choice with our patient users of Livy, that patient-facing chatbot as well. We sometimes hear things like this. Because I'm a person of color, thinking a little bit of the basic care design, because again, I think it just gives it a little bit more of a connection to minorities in our health. This participant reflecting on, why does Livy in the upper left look the way Livy does? This participant is onto something. In the technology world, there's a phenomenon called mirroring. And mirroring is the idea that if you mirror the user's appearance, you may make chatbots more effective at behavior change. Those things like colonoscopy reminders. When Livy reminds me about my colonoscopy, I may be more likely to follow through if Livy looks a little bit like me. An interesting challenge when it comes to AI technologies. Can we design chatbots to achieve the benefits of mirroring, say based on race or gender, without crossing some ethics line into manipulation? I would say that creating digital twins of physicians might cross such a line, but where do we draw the line when it comes to manipulation? So we find ourselves in this ethics balancing act. On the one hand, the more we make AI ever more human and we mirror the user, it could make them more effective and actually more enjoyable to use. There are data to suggest that. On the other hand, the more we make AI human, it risks misidentification and manipulation. It goes back to that first question of transparency, the more human like AI is. Patients and families also tell us about the allure of technology when it comes to AI-based mortality prediction. They worry that having this AI-based prognostic score flagging as a red flag in the EHR creates a focus, a streetlight phenomenon, where now clinicians focus only on this prognostic score and overemphasize death and decision-making at the exclusion of quality, family, community, spirituality, and so much more that patients care about, limiting their choices in effect because we as clinicians now come to see patients as a certain way because of that particular score. Another way choice could be affected. But what about clinicians? Clinicians have choices too. And here, when it comes to choice, we often hear that a key safety measure is to keep a human clinician in the loop. If we just keep a human in the loop, all will be well with AI because decisions will be made freely and well-informed. Well, of course, as you can see from the rest of the presentation, the real world is not so simple. We know there's the phenomenon of automation bias. This is the idea that we often follow recommendations from computers unquestioningly, a phenomenon that can be worse when tasks are complex, when cognitive burden is high, and when time pressures are acute. All things that apply to contemporary healthcare today. This is automation bias. I'll show you this again with an example. Here's a study of AI-assisted chest X-ray performance. Back to that. Researchers found that AI helped some and worsened others. What do you think predicts AI-assisted diagnostic success? Is it years of experience in radiology? Is it subspecialty training in thoracic radiology? Is it experience with AI itself? Which would explain your ability to make better diagnoses with AI? The answer is none of those. And this reflects another general point that we at the moment don't really know the circumstances under which AI can help us or harm us in the way we use it in decision making. A major research need moving forward that needs to be tailored to context as well. But there is a general phenomenon that we do see, and that is that poorly performing AI reduces performance, especially for already high performers. This has profound implications for how we think about clinical and diagnostic excellence as we come to integrate AI into our workflows. We do have lessons from history in this regard. Not all of them are positive, I would say, but we have lessons from history. This was a study from years ago of primary care adoption of the EHR in clinical decision support. And in this study, they found that implementation of those technologies actually decreased clinical knowledge, resulted in some cases in lower patient-physician trust, and also lowered confidence in decision-making. An important reminder, not from AI, this wasn't AI, but a reminder of how these tools can affect the way we practice, and really, I would say, venture into the idea of what counts as de-skilling. Are these technologies resulting in something that we would call de-skilling because of the way they're implemented? Now, the researchers in this study were quick to point out that yes, there are system pressures, like I already mentioned, that can affect this. Reduced visit time, quality metrics, all those cognitive demands and so on can contribute to this particular form of de-skilling. But they also importantly point out that there were individual factors as well. We had choices. And the way individuals responded to those pressures, whether by adopting a checklist mentality, using cut and paste to get by, and so on, some of those individual level decisions also contributed to de-skilling. So it wasn't merely a system level phenomenon, important though that is, there were individual level factors as well in the way people responded. And that should be empowering to us, for those of us who care about AI and healthcare, to know that we also have choices with how we use particular technologies. The take-home point here, when it comes to choice, we need to more actively take responsibility, as I just mentioned, while we also continue to examine those system and individual level factors that influence the phenomenon of automation bias. Instead, I would close with something a little bit deeper and hope to have 10 or 15 minutes or so here for questions. And I call this the technology between us. I think that AI is more than just a tool. And I think there's ample literature from sociology, philosophy, and more to support this idea. This is Sherry Turkle's work. She's at MIT. She wrote this particular article about how computers change the way we think, pointing out that these tools change the way we think, whether it's been mathematics, written language, and so much more. Some would even say that PowerPoint as a tool has changed the way we think by forcing me into 3 bullet points in the way I present information to you. So merely a tool, some would say not so much. It affects the fundamental way we talk and transmit information. To illustrate this, let's talk about the promise of ambient note-taking. Those AI-based medical scribes that audio record the visit and turn it into billable encounter notes. This obviously holds great promise. It may help us solve the problem illustrated on the right here, where a pediatric patient colored a picture about what it was like to be at the doctor's office. You see the doctor has their back to the patient and the family typing on the computer. Ambient note-taking has promise to turn us back to the patient, away from that computer. Our own clinic is using this, and it has great potential. And there's a lot of excitement around this particular use. I can tell you, though, that early studies on it are a little bit mixed as far as burnout, pajama time, and so much more. We have a lot more to learn about that particular technology. But is it just a tool, or what might be those subtle influences in the way we think or act, even with ambient note-taking, which for better or worse I would say might subtly change how we practice in certain ways, because now might we have to articulate the physical exam in ways that we wouldn't before so that the AI can hear it and put it into our note? Might there be less or different sharing from patients who are being recorded? Because now it's not just me dictating their story, it's actually their story, their voice going into a different place. Or might it actually reintroduce stigmatizing language into the note, uncovering those biases that we saw previously in large language models? And I can tell you, we have examples of this, or when it comes to the assessment and plan, these AI technologies might use things like frequent flyer, reintroducing stigma into the note because of this technology. These subtle ways that something we call a tool changes what we do and how we practice. I'll illustrate this in one more way. We in our clinic also use large language models as that first smart reply to patient portal messages. This is an example of a message that I might receive. It's a real one. I'm sharing it with permission. Dr. DeCamp, hope all is well. I received a message yesterday to schedule fluoroscopy. I think this may have been for my swallowing issues. Since then, I think things have definitely been fine. So if it's okay with you, I won't follow through with the test. I continue to have that persistent dry cough. Should I do anything about it? Let me know your thoughts. Luckily, I've been feeling great. I think a very representative example of the types of messages we get in primary care. This is AI's initial response. Thank you for your message. It's good to hear that your swallowing issues have improved. You're not experiencing any problems. It's reasonable to postpone the fluoroscopy. However, if symptoms return, we should reconsider. Regarding your persistent dry cough, notice how it saw two different issues. It's doing a pretty good job here. It's important to monitor this. If it continues or worsens, we should investigate further. I'm glad to hear you're feeling well overall and have rescheduled your colonoscopy. 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 Didn't see that in the message, right? It's doing so well until it hallucinates something. And then lastly, notice the disclaimer we put on this text. This text was automatically generated, then edited, in this case, not edited, by myself. Was this enough for the sake of transparency? We didn't say AI. We didn't say computer. We said automatically generated, reflecting that question of how much do we disclose? So a powerful technology that does so well until it doesn't. But what about technology and how we view each other? Why do I bring up these AI-based smart replies? Well, here's a study from Outside Medicine that, if replicated in healthcare, would I think be really challenging from an ethics perspective. In this non-healthcare study, perceived use of those smart replies caused the recipient, who could be a patient, to review the sender, who could be a physician, more negatively. But actual use caused the recipient, who could be a patient, to review the sender, who could be a physician, more positively. Think on that for a second, and you'll realize that it supports relationships, but only if patients don't know it. Bringing us full circle to the challenge of transparency in what we tell people and how we engage with AI. Last thought here. I want you to beware of these comparative studies of AI versus humans. Don't take off your critical thinking hats and the way we think about clinical studies when it comes to comparative studies. This is one that got a lot of attention, and it said that ChatGPT is more empathetic than your physician, is what the headline said. The researchers found that ChatGPT responses were longer, higher in quality, and more empathetic, as you can see in the graph at the lower left, than physician responses. Don't take off that critical thinking hat. These were only 195 questions where the responses were generated either by the chatbot or a person on a public online forum. These were physician responses to people on Reddit. Okay? In other words, these were not evaluated in the setting of healing relationships, where what I might individually say to a patient at any one time might be longer or shorter. I'd venture to say that many of us would respond differently within our own patient care practices than we would to people we don't know on the platform of Reddit. So beware comparative studies. So I'll close just by saying, of course, we need to disclose the use of AI. We need to understand its data and its performance for harms and biases, and consider where that line is for de-skilling as we rely on technologies. We also have to keep in mind the subtle ways these AI tools change who we are, what we do, what we value, and so much more. And I'll stop there, and I'm happy to take any questions or comments. Thanks for your time.
Thank you so much. That was wonderful. Fantastic. Let's see here. Jean, you have a question?
Great. I was actually clapping, but I'll raise my hand too. Thanks so much, Matt. That was fabulous. You hedged a little bit. You came back to it at the end around this issue of transparency, right? And sort of what is the right amount of transparency? The wording is really important, as you said, sort of automatically generated or not. I know different systems have chosen not to disclose the sort of chat generated
True.
responses. I think that's been a matter of debate, but where do you feel if you had to weigh in, I'm going to put you on the spot, like where do you think it's really critical, right? I mean, is it that chat response, or is it, something else that directly affects the care? Or where do you think the line is?
Well, great question. It may be hard to draw the line perfectly, but I would say that when it comes to the so-called generative technologies, particularly the ones that end up directly facing patients, there I think the obligation of disclosure is more clear, at least for right now, at least while it's still new. I am concerned if, with open notes models, patients also can go in and see the note that was generated in part by AI. And I think that's another case where disclosure is key. Yes, our health system had that same debate about whether to include the disclaimer at the end of the large language model message. And by the way, I can see the other side of it. The other side says, look, clinician, when you adopt that smart reply and you edit it or not and hit send, you've now taken responsibility for it. And there's no reason to disclose that it came in part from AI. I understand that that's part of the opposing view. On the other hand, the way it changes how things are said and what's said, I think those patient-facing uses have a much clearer obligation for disclosure right now compared to, say, something that might inform my decision-making in the background because it's a predictive analytic. Partly because, I don't often take patients, well, this is exactly how your ASCVD score was calculated. Right? We don't do that. And I think that's probably okay. So I would say in general, I'm much more concerned about the patient-facing aspects.
Yeah, thanks. And I'm glad you pointed out that article because I had the same. I think that is important to say. So I was like, what physician would actually write some of those things back? Anyway, thank you. Thank you.
Thanks.
Okay, we have another question from Ishani. Can you unmute yourself?
Yeah, I was curious to know if you had any comments on what the legislative space looks like around, especially like AI in medicine. And I personally don't see a reason why there shouldn't be a standard protocolized way of it always being disclosed to patients, because in my personal opinion, there's really no reason to withhold that information from patients or people in general if AI is being used.
Yeah, great. Thanks for bringing that up. And in fact, I'll add to what you said and say that some people see the way we're reacting to AI right now to actually be condemnation of our prior practice. They might say, well, look, this is revealing this issue, but in fact, DeCamp, you should be telling people that the first read of their EKG came from a computer. Now, this goes back to Jean's question a moment ago. I think we do need more research to understand how patients interpret the language we use in disclosure. Do they care that it's AI? Do they want to just know it's a computer? What do they want to know? I think there's a great research need there to help inform this policy. The debates we're having even about transparency. So I can understand that. I don't know that the legislative space will do something like translate the AMA guidelines into law. There is a lot going on in this space. You may have heard that a bill that came up a couple of years ago is now back up. That's to allow AI to be an autonomous prescriber. If FDA approved and if deemed a prescriber by the state medical practice laws, the idea is that AI could be a prescriber in certain circumstances. We might all be able to think of specific clinical scenarios where actually that might be okay. very narrowly defined, I'm sure. But maybe for uncomplicated cystitis, maybe it could. I don't know. It's an interesting part of the legislative debate in that sense as well. Last thing I would say is that FDA, at least heretofore, really did take a risk-based approach to the demands placed on AI-enabled tools. And I do think that's the right way to think about it. I actually do think that the what we expect of disclosure should go alongside with what we think about risk. And the more risky it is, the more our obligations of disclosure go up. And that may be one way of thinking about it. So in other words, maybe, yes, we disclose always, but the burden of disclosure goes up with the way we think about risk. So that's a great question. Thanks for that.
So Matt, as a follow-up, I think the idea that, we need to understand the black box, from your talk, it came, I think we actually do need to understand the black box because of the biases, right? Because if we didn't understand how it works, we wouldn't know there are all these biases involved in the input that goes in, right?
Great comment. In fact, in our interviews with clinicians about AI-based mortality prediction, some of them who care most about bias appear to care most about explainability. I just personally am sort of an all else equal around explainability. I wouldn't say that we have to have explainability at the expense of an accurate model. And then also say that when I talk about this to tech people, some people say this. They say, well, here's the thing with explainability. Some say this. You can always get to explainability. It's just a matter of how hard you try. And that's a different ethics issue now. Now it's about how hard and how far we go to demand explainability in models where it's possible. So some tech people would say, well, if you really care about explainability, then we need resources and time to get there. It's not just yes or no.
Naresh, you had a question.
Thank you so much for the great talk. Building off that question, since these, I mean, a screwdriver is a screwdriver is a screwdriver, right? But like these models are not static. Is there ever a possibility where we can explain it in a current mode, but then how do we account for the known hallucinations, the evolving effect of the model and such going forward?
That is a great question. That, maybe it just reinforces I don't have the answer to that question, but maybe it does reinforce the idea of our need to continually evaluate and probe models. We sometimes like to think that we can do all of the analysis and evaluation up front and launch it and then let it go. But I think your question is pointing out that we can't do that. Yeah. Right? This idea of evaluating performance, explainability, biases over time is really important. In fact, I'm most concerned about the biases that emerge over time. I didn't talk about that today, but I'm most concerned about biases that can emerge over time as a model is in the real world, could potentially learn as it goes. It gets stuck into negative feedback loops. Performance gets worse over time. If we're not evaluating it, we won't know it.
Yeah, I mean, and to just quickly build off that, like these studies that show attitude surveys are great, but I'm hoping we as a medical community like demand more clinical outcomes, right, with these trials. Whether even these risk scores, I don't even know. When going back, have they improved outcomes in terms of cardiovascular pathology prevention and such? I'm hoping we can have AI do that and look at that over time. So,
yeah. Thanks for that. I agree.
Yeah.
I think we've run out of time. So thank you so much, Matthew. That was wonderful. It was a great talk. Thank you.
Thanks for all the questions. Yeah, good to see you.
Thank you.
Very much.
Thank you. Bye.